Hello, I'm Dr. Benjamin Strong, the Chief Medical Officer of Virtual Radiologic, or vRad. Thank you for joining me for this presentation on endotracheal intubation complications. Endotracheal intubation complications are common, especially in the emergency imaging world. So these are things that any radiologist engaged in emergency imaging needs to be constantly on the lookout for. I've altered the format of this presentation ever so slightly. This one will have a combination of radiographs and CT scans, each demonstrating one of the various complications of endotracheal intubation. Our next case is a hyperinflation of the endotracheal tube cuff resulting in tracheal laceration or rupture. You can see there's extensive extrathoracic soft tissue gas as well as extensive pneumomediastinum. Let's look at the pneumomediastinum, nicely outlining the aortic knob and the left aspect of the heart. And then here is that hyperinflated endotracheal tube cuff. You can see well beyond the confines, the expected confines of a normal trachea. That's far too much gas, far too much air to have placed in that balloon, and it has ruptured this patient's trachea. Here we are with the companion CT scan. This one is a rupture of the posterior tracheal membrane, most likely related to the stylus that goes inside the endotracheal tube, although possibly related to the tip of the endotracheal tube itself. So you can see there is extrathoracic soft tissue gas and extensive pneumomediastinum. And here you can even see the focal defect in that posterior tracheal membrane just beyond the tip of the endotracheal tube. We can track that endotracheal tube to that defect, which again might be related to the presence of the stylus or just forceful introduction of the tip of the tube itself. But that small rent there in the posterior tracheal membrane has resulted in massive extrathoracic soft tissue gas and massive pneumomediastinum. Covered stent is usually the approach to such injuries. So that is a tracheal laceration related to endotracheal intubation. Our next case is a common and easily corrected complication, that of right mainstem or bronchus intermedius intubation. You can see there is clearly an endotracheal tube with its tip extending well below the carina and as a result jailing the left mainstem bronchus. There is associated atelectasis of the left lung manifesting as consolidation, volume loss, and narrowed rib interspaces. So again, easily corrected. Typically all that has to be done is to withdraw the tube a certain distance and free up that left mainstem bronchus, getting it into the appropriate position at least 2 centimeters above the carina. Our companion case for this is an aggressive right mainstem / bronchus intermedius intubation with laceration or transection of the bronchus intermedius. So you can see here the bronchus intermedius is not visible. We should see an air column at this level here below the carina, and it is not visible. There's also a large hydropneumothorax present, and there's significant volume loss of the right lung related to near complete atelectasis of the right lower and middle lobes. There's the cine, and you can see the bronchus intermedius vanishes. There's a tiny bit of residual gas in the remaining lower right lung. In fact, if you note, the branching pattern lets you identify the atelectatic right middle and lower lobes. Let's look at that one more time. You can see the bronchus intermedius taper off and that branching pattern of right middle and lower lobe. Here on the coronal, you can much more clearly see the transection of the bronchus intermedius, again that disruption of the gas column. In addition, look at the horizontal fissure, and you can see it so clearly that you can much more easily identify atelectatic right middle lobe and lower lobe on this coronal view. So there is that transection, actual separation of the bronchus intermedius, and a clearly atelectatic right middle and lower lobe. This case was so traumatic, there was actually an associated small focus of extravasation related to pulmonary vessel injury. That's an important finding to note, especially in the presence of all these other distractors. So again, that is a bronchus intermedius transection related to endotracheal intubation. All right, we move to the other side. This is an apparent complication. This is a left mainstem bronchus intubation. But I'd like to point out the left mainstem bronchus intubations are rarely accidental. Two reasons can lead to this result. One is the use of a dual lumen tube, which is actually the case here. I can't tell exactly why we can't see the second lumen. Sometimes they are dim. Sometimes the markers are of a different style that are hard to see. Sometimes motion can complicate things. But in any case, we checked with the clinical team, and this was in fact a dual lumen tube. You can see the tip of the dual lumen tube, the longer lumen, is present in the left mainstem bronchus, but the right lung is fully aerated, showing clearly that the right mainstem bronchus is not jailed in this instance. These dual lumen tubes are frequently used in the surgical setting when they are working on one lung or the other and want to minimize the barotrauma to that lung. So you can see consistent with this are these postoperative changes on the right. So they were using a dual lumen tube to limit the expansion of the right lung while they were operating, and now have got both lumens functioning normally and both lungs are aerated. So I think the takeaway point here is that second lumen of a dual lumen tube can be hard to see, and left mainstem bronchus intubation is quite frequently intentional. Here's a CT companion case of left mainstem bronchus intubation. Again, intentional. This is a severely traumatized patient. You can see there is an acutely life-threatening laceration of the anterior aspect of the ascending aorta with associated mediastinal hematoma. But in addition, there are markedly displaced anterior right rib fractures. There is consolidation and volume loss of the right lung consistent with hemorrhagic contusion. There is debris and dependent liquid in the right bronchus intermedius consistent with hemorrhage. That can be a real problem in that it can spill over the carina into the normal left lung and clot and cause bronchial obstruction in the opposite, otherwise normally functioning lung. And here is the tip of that endotracheal tube in the left mainstem bronchus. Again, in this setting, this was done intentionally. There again is that aortic laceration, the most important finding here. So here we see the aortic laceration, but then we'll also focus on the rib fractures, the consolidation of the right upper lung, and then lastly, let's follow that endotracheal tube to its tip lying in the left mainstem bronchus. All right, so that is a left mainstem intubation. Again, an intentional act on the part of the emergency room doctor. He saw the extensively traumatized right hemithorax. He saw the blood bubbling up from the bronchus intermedius when he intubated the patient, and he chose to intubate the left mainstem, thus jailing the right mainstem bronchus, protecting the right lung from barotrauma and protecting the left lung from bronchial hemorrhage. A very heads-up move by this quick-thinking emergency physician. All right, moving on to our next complications. I don't have companion x-rays for these, but these next two cases are both the dreaded complication of ankylosing spondylitis, and that is a transverse or banana fracture of the upper thoracic or lower cervical spine from intubation in ankylosing spondylitis patients. Of course, ankylosing spondylitis causes such a stiff and inflexible spine that when the patient is put into the sniff position for intubation, it can snap the spine. And that is what we have here. You can see this irregular transverse lucency. The entirety of this patient's spine is fused, so no disc spaces are visible at any other level in the spine. So it's interesting how that makes this stand out, this axial irregular lucency. In addition, note there is fusion of the costotransverse joints. Those are synovial joints, and they do fuse in extreme cases of ankylosing spondylitis. Lastly, there is gas in the extrathoracic soft tissues. That's related to this inappropriate extrathoracic positioning of a right chest tube. Lower down, you can see again fusion of the costotransverse joint. There are also additional gas collections here. One of them is in the spinal canal. That's actually epidural gas. It's related to the soft tissue gas from the poor positioning of the right chest tube and that transverse fracture which allows it access to the spinal canal. Lastly, we have a left chest tube which at least is in intrathoracic position, but it's passing through the pulmonary parenchyma and thus still not appropriately placed. Lastly, let's note the fusion of the sacroiliac joints. That is a necessary finding in the diagnosis of ankylosing spondylitis. When I am looking at a seemingly fused spine and wondering if it is ankylosing spondylitis, I go immediately to that patient's sacroiliac joints. If they're fused, the diagnosis is confirmed. If they are not, I begin considering other causes for the findings I'm viewing. Here we are in lung windows. We can see again the extrathoracic soft tissue gas. But here on abdominal windows, we see the definitive finding, and that is a cricothyrotomy incision. You can see there is actual dressing material and a tract in the anterior cervical soft tissues. So what happened is this patient was undergoing intubation. They felt the snap of the inflexible cervicothoracic spine fracturing, and then it became an emergent airway management situation that required an emergent cricothyrotomy. So you see the results of that here. They subsequently then were able to pass an endotracheal tube through the normal means and did actually get a normal endotracheal intubation performed. So here again is that transverse irregular lucency through an otherwise fused spine. Note the costotransverse fusion and the epidural gas present here. And then let's get a cine view of those fused ankylosing spondylitis sacroiliac joints. Next on the lung windows, you can see that epidural gas collection. Not a typical finding. And then lastly, that cricothyrotomy incision and the inappropriate placement of an extrathoracic chest tube and an intraparenchymal chest tube on the right and left. All right, so that is ankylosing spondylitis with a pathologic banana fracture related to endotracheal intubation and necessitating an emergent cricothyrotomy. We'll finish up with a similar case. This is another case of ankylosing spondylitis. This patient presented with a large inflammatory pannus, severe spinal canal narrowing at the C1, C2 level that was causing a spastic paraplegia and respiratory distress. That in turn necessitated emergent intubation, which resulted in a banana fracture there at the C7-T1 level. And that involves the facet joints as well, as you can see on the midline reconstructed sagittal CT. All of this then resulted in the placement of an emergency cricothyrotomy tube, which you can see both on the CT on the left and in the MR on the right there passing into the trachea. So a little more detail. Here's the inflammatory pannus causing a marked separation of the atlantoaxial joint and severe canal narrowing. There's the fusion of the spine, that stiff and inflexible spine that then broke here at the C7T1 level and necessitated the placement of a cricothyrotomy tube. We'll look at the cine one last time. There's the fracture, the pannus, and the cricothyrotomy tube, all making a complete story. So an impressive case of ankylosing spondylitis with a subsequent banana fracture resulting from intubation, a not uncommon complication of ankylosing spondylitis. And that concludes our review of endotracheal intubation complications. Thanks again for joining me, and we'll see you on another lecture very soon.